This is a recorded lecture for Medicine 1 and the topic is hemoptysis. Hemoptysis is the expectoration of blood from the respiratory tract, and it can occur from any location starting from the alveoli up to the glottis. It should be distinguished from other sources of bleeding, such as from the nasopharynx, which is called epistaxis, and bleeding from the upper gastrointestinal tract, which is called hematemesis. The most common cause of hemoptysis is infection of the medium-sized airways. Most of the time, it is just viral or bacterial infection, but worldwide, the most common cause would still be Mycobacterium tuberculosis. Diffuse alveolar hemorrhage may occur with bleeding in the alveolar space. It can be both inflammatory or non-inflammatory, an example of which is small vessel vasculitis. The alveoli may also bleed due to direct injury. It can be in the form of thermal injury, exposure to toxic chemicals, illicit substances such as cocaine, and direct trauma from suctioning or a foreign body. In the developing world, massive life-threatening hemoptysis occurs with tuberculosis. This may result from the formation of a Rasmussen's aneurysm, which is a dilatation of the pulmonary artery in a cavity formed by a previous tuberculosis infection. Infection, with its resulting inflammation, may result into tissue necrosis with accompanying cavitation of the lung parenchyma, and this may result into bleeding once erosion occurs into the blood vessels. Bronchiectasis, the permanent and abnormal dilatation and destruction of the major bronchi and bronchial walls, may also result into bleeding in the airways. Paragoniomyces is a fluke infection transmitted by a consumption of raw or undercooked crab or crayfish caused by Paragonimus westermani. It presents with fever, cough, and hemoptysis. Paragoniomyces should be considered in patients from endemic areas presenting with hemoptysis. Only 10% of cancers would manifest primarily as hemoptysis. Squamous cell and small cell carcinomas are commonly found in or adjacent to the proximal airways, which are more likely to cause hemoptysis. Combination of multiple pulmonary nodules and hemoptysis should raise the suspicion of metastatic disease. Congestive heart failure with the elevation of left atrial pressures may result into the rupture of small alveolar capillaries, which may result into pink frothy sputum. Women with monthly hemoptysis suggest catamenial hemoptysis resulting from pulmonary endometriosis. Patients presenting with hemoptysis should be asked how much blood has been coughed up in the past 24 to 48 hours. Is the blood mixed with phlegm? Is the phlegm clear, white, or purulent? When was the first time that the hemoptysis occurred? Is the hemoptysis new or a recurrent symptom? Is there any bleeding accompanied from the nose, gums, stomach, or rectum? Is the patient dyspneic? And does the patient raise phlegm without hemoptysis daily or frequently? Are there other symptoms that suggest infections, like fever, chills, night sweats, and purulent sputum? Has the patient had a skin rash? Has the patient lost weight, any headache, or bone pain? For patients with hemoptysis, aside from a careful history and physical examination, determining the volume or the amount of bleeding is important, and classifying between massive, moderate, and mild would help with the diagnosis. Mild hemoptysis is defined as presence of specks of blood in the sputum or blood-tinged sputum. It is often caused by infection and is usually managed as outpatient. Massive hemoptysis is large volume hemoptysis, variably defined as more than 200 to 600 ml in 24 hours. This condition is life-threatening, Although exsanguination from hemoptysis is rare, drowning from aspirated blood is the usual cause of demise. Moderate hemoptysis is defined as specks of blood to around 200 ml in 24 hours. This is somewhere in between the mild and massive hemoptysis. This is a non-life-threatening condition, unlike your massive hemoptysis. Patients with hemoptysis presenting as massive volumes should have their airway secured to prevent asphyxiation. If the bleeding continues, embolization and/or resection of the bleeding area should be considered. If the bleeding stops, further workup should be done to determine the underlying cause. Patients presenting with moderate hemoptysis may undergo diagnostic tests such as a chest X-ray, CBC, coagulation studies, urinalysis, and creatinine determination. If the results are indeterminate, a chest CT scan may be warranted, as well as bronchoscopy, which may be both be diagnostic and therapeutic. Mild bleeding, if with the presence of risk factors such as smoking and family history of cancer, may require CT scan and/or bronchoscopy. If there are no risk factors, they may be managed as an outpatient. For the acute management of massive hemoptysis, the priorities are to protect the airway and give adequate ventilation, to preserve cardiovascular function, and putting in a tube or intubation if needed. Stopping the bleeding by reversing coagulation disorders if present, protect the good lung from spillage, and allowing the clot to clog the draining bronchi. Bronchoscopy may be done to provide balloon tamponade, and bronchial arteriography and embolization may be done for massive bleeding. Surgery is also an option by removing the bleeding area. Selective intubation may be done by inserting an endotracheal tube and positioned on the side that is not bleeding. So in this case, if the right side is filling up with blood, endotracheal intubation with the left main stem bronchus may secure the airway. A chest CT scan may be warranted to localize the bleeding site and diagnose the cause of hemoptysis. Bronchiectasis, lung abscess, mass lesions such as cancer, mycotomas, and AV malformations may be seen. This will also guide arteriography or bronchoscopy to the regions of highest yield. Fiber optic bronchoscopy may be done as shown in this image to rule out endobronchial malignancy in a patient with hemoptysis with a normal or non-localizing chest X-ray or with risk factors for malignancy. It has the highest yield for localizing the bleeding site if performed during active bleeding. Cauterization and laser therapy may also be done through fiber optic bronchoscopy. For continuing hemoptysis with an unknown source, arteriography may be done, which would have both diagnostic and therapeutic value. Once the bleeding site is determined, angiographic embolization of the bleeding artery may be done. Most cases of hemoptysis resolve with the treatment of the infection or inflammatory process. However, persistent hemoptysis may require special evaluation according to the category of disease. So for tracheobronchial disorders, examination of expectorated sputum for TB, parasites, and fungi may be required. For localized parenchymal diseases, chest CT scan with the lung biopsy and special stains may be required. Patients suspected to have diffuse parenchymal diseases should have their expectorated sputum sent for cytology. Their blood checked for BUN, creatinine, ANA, RF, complement, cryoglobulins, and anti-GBM antibody. Special staining after lung or kidney biopsy may determine the cause of diffuse parenchymal diseases. Cardiovascular disorders may require an echocardiogram, an arterial blood gas, ventilation perfusion scans, pulmonary arteriogram, an aortogram, or a contrast-enhanced CT scan. while hematologic disorders may be determined with coagulation studies and bone marrow studies. For patients presenting with hemoptysis, there is no substitute to careful history and physical examination.